We hold the policymakers accountable. We hold the providers accountable. We will hold even the lawmakers accountable to ensure that we are able to get the value for the resources that we expend on health. So I'll be anchoring this event today alongside my colleague, Okoyemi Noluakwo, that will be anchoring this event together. So let's know who is in the room. I would like to quickly introduce ourselves. And for our virtual participants, please try as much as possible in the chat box, put your name, designation, and organization so that we'll know who is participating in this event. So before we pass the microphone around, I would like to recognize the presence of Dr. Idris Muhammad, who is the chair of the board of HEFON. You are welcome, sir. And then I would like to recognize the presence of our own Dr. Celeste Okori, who is Executive Director for HEFON, if I'm correct. So, so what we'll do quickly, we'll pass the microphone around. Let's quickly introduce ourselves and our designation and organizations quickly. I would like to start from you. So.
Thank you very much. Good morning, everybody. My name is Hope Ahamba. I'm the National Coordinator of Initiative for Rural Development and Peace, IRODP.
Good morning, everybody. Happy to be here. My name is Bosede Akimbolushiri, Executive Director, Development Initiative for Community Enhancement, DICE. Thank you.
Good morning, everyone. My name is Sekina Hamza, and I work with the BHCPF unit of the National Primary Healthcare Development Agency.
Good morning, everyone. I'm by name Imuna Abdullahi, and I work with Africa Health Budget Network.
And the vaccines and essential.
Specialist on the pneumonia control project.
Good morning. My name is Abdullahi Magama. I also work with Save the Children as a project manager.
Good morning, everyone. My name is Jamila Mohammed Gentabu, and I work with LISDEL, and I also support the BHCPF Secretariat on Knowledge Management and Communication.
Good morning, all. My name is Jamila Mohammed Ahir from Secretary, Knowledge Management and Communication, Kaduna Maternal Accountability.
Nigeria as Senior Evidence Advisor for the E4MMA project. Thank you.
Good morning, all. My name is Alhaji Godwin. I'm a Senior Manager with National Health Insurance Scheme.
Good morning, everybody. My name is Emma Bassi. I work with Clinton Health Access Initiative.
Good morning, all. My name is Igodalo Samuel, Project Manager in Nemo Foundation.
Good morning, all. My name is Okechukwu Ndaguba. I'm an Assistant General Manager with the National Health Insurance Scheme.
Good morning, all. My name is Kiru Salawuddin. I work with National Health Insurance Scheme.
Good morning, all. My name is Abdulkadir Abdurraouf. I work with LISDEL, Health System Strengthening Specialist.
Good morning, all. My name is Okara Dogara. I work for Federal Ministry of Health, Basic Healthcare Provision Fund, Secretariat. Thank you.
Good morning, everyone. My name is Juliana Abude Aribo, and I work with LISDEL.
Good morning, Chairman. Good morning, everyone. Dr. Francis Ukuije, Health Economist, WHO Nigeria.
So thank you very much for introducing yourself. Before I move to the goodwill messages from our partners, let me further add to the stage that we've already said. This process actually started some years back, like 3-4 years, where a sector reform coalition set up a financing subcommittee, and that committee was saddled with responsibility of doing a lot of things, including developing accountability framework, and HEFON played a very, very important role. We actually reviewed the existing evidence, tried to develop a draft document. We had a series of engagement with partners, and this is a continuation of the exercise. And hopefully this time around we are going to have a lot of traction and to make us achieve the objective. So I would like to invite some of partners here that are supporting the process to give the goodwill messages. So I would like to invite Dr. Francis Okwije, who is representing the World Health Organization. Dr. Francis, over to you.
Thank you very much, Dr. Gafar. Chairman, my colleagues, I bring you greetings from the WHO Nigeria representative, Dr. Walter Kazadi Mulumbo, and to say that WHO is fully in support of developing accountability framework for health financing and basic healthcare provision fund in Nigeria. In previous occasions, the WR had made pledges to the government of Nigeria through the Honorable Minister of Health for WHO to support this. The reason is very simple. As laudable as every initiative is, if it is not implemented, it's not going to achieve its set objectives. And the Basic Healthcare Provision Fund health financing in Nigeria, we believe that the Basic Healthcare Provision Fund is the game changer in health financing reforms in the country. And we believe that if we are able to have a system that will track progress while holding the implementers accountable, that it will really make a lot of sense. As much as we know that civil society is not a police or an investigating part or investigating body for government. Sometimes a lot of people misconstrue the role of the civil society. We actually recognize civil society as partners in progress, partners towards achieving the roles of government. And actually, because of the collaborative leadership we see in universal health coverage, we cannot overstate the role of civil society, even in this accountability framework. So we are happy to be connected and committed to this process, and WHO will continue to support this until we see that we have a system of accountability that is working in Nigeria for health financing and basic healthcare provision fund. At this point, I want to congratulate you once more. We believe we are going to have good deliberations, and that the objectives for this particular stakeholders meeting will be met. Thanks a lot.
So thank you very much, Dr. Francis. So the watchword is the accountability system that works. We will take all the goodwill messages, then we'll hear from our father in the house before he gives some opening remarks. In this southwest of the country, they said, is the biggest masquerade that actually dances last. So let me invite the Executive Director of Legislative Initiative for Sustainable Development, that is playing a very, very important role, providing a huge amount of resources to support this. So I would like to invite Juliana Aribo-Abude to give you some goodwill message. Over to you.
Thank you, my Oga, Dr. Gafar. He's actually my Oga. Good morning, everyone. It's really great to see you here, and I hope that you all slept well. Please permit me, Chairman, to stand on existing protocols already established by almighty WHO. So who is LISDEL to speak when WHO has spoken? I will just build or ride on the momentum that Dr. Francis has already established to say that I've been a member of the Health Sector Reform Coalition for years. I think since it was established to lead the enactment of the National Health Act in 2013. I didn't go for the march because I was pregnant with let me not tell you the number of the child, so that I was pregnant with one of my plenty children at that time, so I couldn't go for that march in 2011, not 2013. So it's really gratifying for me to see that we are here today. We developed the health financing framework shortly after in 2018, and had participation as we have today from the sector generally. And although we haven't been able to develop an action plan for the health financing framework as it is, the accountability framework itself is really very comprehensive. And that's why we are working to see this basic healthcare provision fund accountability framework be derived from it. In collaboration with HEFON and the Basic Healthcare Provision Fund MOC Secretariat. I would like to, I know it's a goodwill message, but let me just put a charge in it. Charge all of us, because I'm a member of the committee as well, to this time, to not let the ball drop, and perhaps not also sit back to complain that HEFON is not doing what it should be doing, because we are all members of the Health Sector Reform Coalition. And once we have these documents, we should be able to do something with it for ourselves, not just as institutions represented as members of the Health Sector Coalition, or as institutions that work in the health sector, but for us as Nigerians. This is Nigerian-led with some support from partners like WHO, the Gates Foundation, AHBN, and others. But first and foremost, let's do this as Nigerians who are willing to see the health sector work and to hold ourselves to account, and not just the government, but to hold ourselves to account to ensure that this is operationalized. Subsequently, we hope to have a dashboard where we will upload results from tracking and every other thing, and we look forward to the processes that will come out of this 2 days workshop. So I wish us all successful, fruitful deliberations, rich conversations. I look forward to this, being mindful, of course, of the time, and also what we will do with this going forward. Thank you for being here today. Thank you.
So thank you very much, Juliana, for that succinct. So let me invite African Health Budget Network to quickly give a goodwill message.
Thank you, Dr. Gafar. Good morning, everyone. My name is Maimuna Abdullahi, and I'm representing the coordinator of Africa Health Budget Network. He is currently unable to make it for this engagement, but then he sends his regards to all the stakeholders present. AHBN is very excited to be participating at this very important engagement today. And our work at AHBN focuses on improving and strengthening health financing accountability in Africa. And therefore, here in Nigeria, we are also committed to support the Nigerian government to ensure that we have an accountability financing system in place. We would like to align with other partners that the importance of health financing accountability cannot be overemphasized, and therefore having a harnessed health financing accountability framework is very important, as this is going to help all the implementers to be held accountable. We would like to encourage all the stakeholders present today to be very dedicated in order to ensure that by the end of the 2 days workshop, we have all the stated objectives attained. And with this, we would like to wish all the stakeholders present a very successful deliberation. Thank you.
Great, thank you very much. I don't know whether West African Public Health Institute is here. West African Institute for Public Health. Online, so should we take we would like to take the goodwill message of West African Institute for Public Health. Can we allow them to speak, please? So probably where we're still sorting the technology over there, I have DGI consult as well. So on this note, I will switch my hat to somebody that will give a goodwill message, not the anchor at this time. So I represent a DGI consult, organization that is established to promote good governance in development sector, including health. And accountability is one of the areas that we attach, one of the areas we attach great importance to. We are part of this process from the beginning, and we are happy that we are gaining traction. We are far more interested in seeing accountability framework that works, like Francis said, and not only at the national level, state level, but at the facility level where the people are supposed to be getting access to healthcare without suffering financial hardship. So we wish all the stakeholders a good deliberation, and we look forward to the very good outcome of this process that will take us to improving the accountability bar or raising the accountability bar in the health sector. So do we now have WAF? Okay, not yet. So on this note, I would like to invite Dr. Idris Mohammed, the chairman board of HEFON, to give us the opening remarks, to give us a overall vision of HEFON for improving the accountability bar in the health sector. Over to you, sir.
Good morning once more to every participant here present this morning. I want to specifically recognize Dr. Francis from WHO, Juliana from LISDEL. Dr. Magashi is not here, but she sent a representative, the African Budget Health Network, and all other participants at this meeting. Once more, good morning. Most of the times when I'm invited to give any kind of a remark, I'm always conscious of the time. So in order to avoid unnecessary distraction, health industry. Accordingly, the following are some of the objectives of the workshop. I believe the agenda you are given has those objectives already listed, so I wouldn't bother to go through them, but to stress the point that as CSOs, our need and aspirations is really to collaborate with state actors. I think time has come when we should be talking about partnership and not working on islands. We will never be able to achieve a robust health system we have as a country. So, distinguished ladies and gentlemen, you will agree with me that the workshop is very important. It's an important event. Therefore, I wish to call on all of you to participate fully in this workshop. The need for active participation by all is informed by the fact that the desired accountability landscape will remain a mirage without a robust accountability framework for health financing and to provide guidance on what information we wish to collect along with the health financing mechanisms and how to use such information to hold different actors accountable. If you recall, the WHO representative really listed all the actors, and I want to reiterate those actors. Not only the state actors, government and affiliations, but also the CSOs and partners and donors. In fact, everybody must be accountable. And for us in Nigeria, I think this is what we're missing at the moment. In addition, I believe that all stakeholders need to agree on a systematic approach for the collection and use of information on government health spending, prepayment mechanisms, external health financing, and other innovative funding sources, and the use of such information to ask relevant questions that will lead to a change of policy and practice, thereby improving accountability on the part of all stakeholders involved in health financing. Here in Nigeria, we know that a lot of money is being spent, even though we are not able to meet the 15% budget suggestion by WHO, or which we actually have agreed to in Nigeria in 2001. The point is still that the little that is available to health resources in Nigeria certainly there's no accountability for it, and much of what we do not speak to the amount of money that we are using. So the need for this accountability framework becomes very necessary. Before I conclude my opening remarks, kindly permit me to, on behalf of HAFON, the Health Reform Coalition, to thank our supporters, WHO, LISDEL, DGI Consult, and even the Federal Ministry of Health. We appreciate the gesture, and we really appreciate this generosity and the collaboration to partner so that we can have a unique accountability framework for health care financing that will be acceptable to all of us and we can use for betterment of the funds allocated to health in Nigeria. we would like to assure you that HAFON, along with Health Sector Reform Coalition, will do all that is possible to do in order to implement whatever decisions we reach at this workshop for the benefit of all. Thank you very much for listening, and I thank you for your time.
Thank you, sir. I think Mr. Chair deserves a stronger round of applause, please. He said a lot of important things, but one thing that actually struck me was that even the resources that we have in the health sector is not buying the best the money can buy. So there's a room for improvement. I was told when I was very young that the largest room in the world is the room for improvement. So it is to achieve that improvement. That's why we are here. So I would like to recognize the representative of the various basic care provision fund gateways present here, the National Health Insurance Scheme representatives, the National Primary Care Development Agency, representative of the AMT gateways, and the National Center for Disease Control. You are welcome. We look forward to having very, very fruitful deliberation. So before we proceed, we would like to know why we are here, to set the objectives, because one of the most important things in accountability is to set the objectives so that it forms the basis for holding ourselves accountable. So I would like to invite Okoyemi to quickly give us the objectives of this forum. Thank you.
A very good morning to you all. Standing on existing protocol, I will just go straight, especially for our online participants. The workshop objectives. Number one is to deepen the knowledge of participants on the concept of accountability in the health sector. The second one is to acquaint the participants with the Health Sector Reform Coalition Health Financing Accountability Framework and validate the framework. The third is to harness experiences from existing accountability initiatives in health sector generally and on the Basic Healthcare Provision Fund in particular. And the fourth one is to forge a consensus on essential elements of Basic Healthcare Provision Fund accountability frameworks, including institutional arrangement for coordinating the Basic Healthcare Provision Fund accountability-related activities. And the last, but not the least, is to develop an action plan for the design, deployment, and knowledge management for the Basic Healthcare Provision Fund accountability framework. Thank you.
Okay, thanks. Let's appreciate him. Okay, that's great. So, okay, let me just give us the objectives of this forum. I think we've set a very, very huge, very big target for ourselves, and we have to work towards achieving all those. The next thing on the agenda, I was told the representative of the Federal Ministry of Health is not yet here. Dr. Ozuma Nwankwo, is he here? Okay, not yet. Oh, sorry, I was misinformed. So now, we are talking about accountability for health financing. Before we know why it is important for us to raise the accountability bar, we have to know the status of financing. We have to understand the landscape. We have to understand where we are in terms of volume of funding, in terms of efficiency of funding, in terms of is the money actually buying what it intends to buy. And to do justice to that, we have in the house Dr. Ozuma Nwankwo from the Federal Ministry of Health, Health Financing Unit. Dr. Ozuma Nwankwo will be making a presentation on Nigerian health financing landscape so that we have a better understanding. Let's appreciate him. Somebody says it's only in Nigeria that we appreciate people before they do the work. Huh? But notwithstanding, let's still appreciate him. So over to you, then. So, please, let's upload his slide deck, please. Can we project his slide deck, please? Okay, Amy. Okay. So I'm sure they will do that very soon. Doc, over to you.
Good morning, everybody. Is it possible to use this screen as well? Because some of the slides have data and graphs on them, and I don't think you're going to appreciate it very much from this, at least for those who are physically here. Do I wait a little bit, or do I could. I'm just pointing out that when I get to the place where it gets very interesting, people will not see. All right. Okay, so good morning, everybody. My name is Ozuma Nwankwo. I head the Healthcare Financing, Equity and Investment branch at the Federal Ministry of Health. I'm glad to be here. And as you know, those who were at the technical working group meeting yesterday, one of the very important conversations were around accountability for the Basic Healthcare Provision Fund. It had been an ongoing conversation. Government is pulling in about at least 1% of consolidated revenue for health, and therefore there is the Secretary of the Ministerial Oversight Committee. One of the challenges is pointed out was some level of interference and whether funds were really going into what they were meant for. And I think that those of us who are in the healthcare financing branch, at least at the Federal Ministry of Health, one very important thing we do is expenditure tracking to show what happens across healthcare financing landscape. So today I'm going to be speaking to those issues, but first, whenever we'll have opportunities like this, we recognize the fact that health financing is a little nuanced, so we try to use every opportunity we'll have to bring people up to speed around, basic concepts of health financing, because a lot of people tend to support people at subnational levels. It's always important to, again, remind people of what the basics and fundamentals. So please forgive me. I'll just run quickly through a couple of things that are really important, and then we'll dive into the substance of the matter. Next slide, please. So like I said, I'll just go through some concepts, and then we'll talk about the strategy and landscape. Next slide. Next slide. Thank you. A lot of us are familiar with this, the graphics you have on the screen, the Sustainable Development Goals. Sustainable Development Goal 3 speaks to universal health coverage. And of course, universal health coverage is a terminology very well known to people in the health sector generally. And for us, specifically in healthcare financing, it is at the heart of a lot of what we do. Next slide. And the UHC cube, at the heart of health financing again, something that any person who is involved in health financing in any capacity at all, be it in supporting implementation or in developing policies, it's important to know everything we're trying to do tries to achieve in universal health coverage what you see in this box. And the idea is that you have a bigger outer cube that represents all of the health that every person, if we're speaking about Nigeria, every person in Nigeria will require. If you look at the horizontal flat line on the x-axis, you would see that you have a population of people who are covered. That represents how many people, whatever you're doing, what sorts of things you're doing, how many people are you reaching? The small cube in the middle shows you, as an example, some fictitious country or state, what it is doing currently. And the goal of everybody is to try to expand that smaller cube in the different dimensions so that it continuously, progressively fills up the box. And the ways to do that is to cover more people. The benefit package you have, expand it in a sustainable pattern so that it covers more services. And in terms of out-of-pocket expenditure, you reduce the amount of monies people are able to pay out of pocket in terms of cost-sharing fees. This is at the heart of what we do in terms of health financing and the drive towards universal health coverage. I always like to show this slide because understanding this slide tells you all the story. Next slide. Now, there are healthcare financing functions. To be able to achieve what I showed you in the previous slide, you would obviously recognize that there is a need for us to raise revenues, pool the revenues together, and then purchase the services. In the subsequent slides, I'll speak to these functions in granular terms. Next slide. Next slide. So in raising revenue, we're referring to, next slide please, we're referring to all the other strategies for which we use to get the money for the interventions. Now, just before I go to that, the whole idea in financing is we try to answer these questions, basic questions of who is paying, how much is being paid, who are we paying, and what services is it that we're paying for, okay? But at the heart of it is the money, right? Next slide. Now, this is a spectrum of what we had spoken to. It is important to raise the revenues, get the monies, now the strategies for health finance, this is why we usually, at opportunities like this, speak to this. A very, very important part of everything we do is risk pooling. And I would tell you later, in later terms, why it is really key. Revenue raising, monies for health, where is it coming from? Government budgets, insurance, donors, philanthropic agencies, all of them. But what do we do? How do we use financing mechanisms and measures to be able to operationalize it for health? Next slide. Next slide. Good. So in order to achieve universal health coverage, how much is it really going to cost? How much are we really looking for? There have been a lot of work on the impact of health and the economy. Professor Jeffrey Sachs in 2001 led a commission on macroeconomics for health, where it was determined that you needed about $34 per capita to be able to achieve some basic level of healthcare for an individual. And since then, there have been other efforts. One of them, and you see a lot of them on the screen, I'll just pick a couple that are important to our conversation. Here, where we put new with the star, is an effort to calculate the cost of basic universal health coverage benefit package, and it is put about $86 per capita. Now, but for those of us who are in Nigeria and in the African region, we are all familiar with the Abuja Declaration, something that is easy to figure out. How much do we think people should contribute for healthcare? The governments of African regions determine 15%, and that's something we've been struggling with till date. Arguments are replete around the fact that health expenditure is embedded in other sectors, and therefore, if we just look at the Ministry of Health budget alone, we're not correctly calculating it. Those arguments have been advanced. Arguments are that health is concurrent, it's spent across all levels, and therefore we need to be able to take all that into account to determine whether government is in up to 15% or not. Next slide. But the point is that these are valid questions for health. I spoke about revenue collection. A lot of the economic analytical work we do at the healthcare financing team estimates all of these indicators you see on the board: out-of-pocket expenditure, general government revenues, externally finance, and insurance. These are mechanisms for raising revenue. There is the very, very common and really broad assumption whenever people talk about universal health coverage to relate it with insurance. That's wrong. Everybody tends to think that even everybody in Nigeria, insurance. Insurance is just one, even small, it's even the smallest mechanism for moving countries and nations towards universal health care. Although that also depends on the model, especially in a country like Nigeria, where we have the huge informal sector. Okay, but we recognize that. Next slide. This is, I thought to put this slide. This slide is borrowed from the Ministerial Oversight Committee Secretary. It shows us one of the biggest, boldest endeavors of the Nigerian government to finance health and raise additional revenue for health, where government is putting down at least 1% of consolidated revenue fund for health. These are the different gateways. When Dr. Chris speaks to us later, she's probably going to delve deeper into this. I guess we're all familiar with this, but this shows you that a lot of money is now going into health, and therefore the need for us to think about how to make these processes accountable. Next slide. Now, risk pooling. Next slide. Next slide. It's not sufficient. Next slide. Next. Thank you. Please go back one. It's not sufficient to just raise these funds. all of us in the room have jobs. We're arguably able to take care of our health, but there is a component of financing that has to do with equity. And that is also tied to the accountability questions. Those who are entrusted with the resources have an obligation to ensure that funds are used equitably. There's the concept of equality and equity, and I think we're all familiar with that. But the idea of pooling is that we're gathering this small income together into a basket of resources so that 10 to 30% of people who usually require healthcare at any particular point in time can use it. Very young people. And next slide. The reason why this is important is for cross-subsidization of risks, right? Based on health needs, there are young university students who are very healthy and arguably in their time in the university might never even need healthcare except maybe treat malaria, paracetamol or something. But then you have senior citizens, the university lecturers in that same community who can have heart diseases, diabetes, who would plunge into healthcare expenditure. If you do not bring these groups together and cross-subsidize risk between healthy and sick, and between rich and poor, and of course the aged and the young, then you miss the idea of healthcare financing. These are important as we work with subnational levels, as they set up their state health insurance schemes, as they utilize the Basic Health Provision Fund to achieve and drive home the equity goal. Next slide, please. These basically are just writing what I had just spoken to. Next slide. Yes, and then when you have gathered these monies together, what do you do with them? Purchasing. Now we're going beyond just discussing purchasing, but we're talking about purchasing in a strategic manner, strategic purchasing. That supposes the ability to make the systems of purchasing a living process. That means you're reflecting the realities of the current time in which you are in. You're not rigid and just holding on to what you have done before. So purchasing, strategic purchasing is one of the important functions. Next slide. For health financing. Next slide. Next slide. These are all there for us. So this is the issue, comparison between just purchasing and strategic purchasing, which I spoke to. Next slide. Okay. So I've just tried to scan through very quickly some basic concepts of healthcare financing, and now I'll be going into taking you through the landscape for financing. At the Federal Ministry of Health, after the National Health Act came into being, this document, the Nigeria Health Financing Policy and Strategy, was developed, and it outlines strategies for the country to achieve, some of what is outlined in the National Health Act, including the financing policy and objectives. Next slide. Next slide. Okay, so in a lot of the work that we do at the Federal Ministry of Health, in trying to point and guide the work of health financing across the country, we additionally, for a long while, been conducting studies called the National Health Account Studies. The Health Account Studies is an expenditure tracking effort. It's an endeavor to ensure that funds that are allotted for health are properly accounted for. Now, these are not budgetary estimates. They are not releases. They are expenditure. Very different from tracking, government A has released this, government B has. We're talking about how it was spent. And to be able to generate this data, we triangulate a lot and use validated reports from auditors, auditor generals of the country and across states and LGAs. And if you look at the screen, you will see a lot of indicators. Without spending a lot of time taking them one after another, you would see that every year from 2015 to 2019, some progress is being made. But let me just point out one. So a couple of them that I think would be useful for our conversation. So the first one is the total health expenditure as a share of GDP. You would see that from 2015 to 2019, we have not exactly made a very tremendous progress, even as our GDP is expanding. We rebased the GDP recently, but healthcare expenditure did not dramatically also follow what we saw in GDP. The other important conversations around financial risk protection is how much money is the ordinary citizen paying for health. And that is the per capita out-of-pocket expenditure. In Naira terms, you would see what that is per person. These slides are there, so you can dig deeper into them. Next slide, please. Now, this is a comparison of Nigeria in the Committee of Nations in the African space. Unfortunately, my pointer is not showing on this LED screen, but Nigeria, it's arranged in alphabetical order. So after Niger, you see Nigeria really dwarfed amongst the other countries, and this is for 2000 and 2016. This reflects what proportion we're spending on health. Next slide. Again, this is another comparison of government expenditure on health as a percentage of total expenditure. Of total health expenditure. So how much is government spend? What is government's contribution in the equation of total health expenditure? If you look again, you will find Nigeria somewhere. Just look for Niger and Nigeria. You see where Nigeria stands, and you see how other nations tower well above the efforts that we make. Next slide. But keep in mind that these are really things that we hope that the BHCPF is able to change with its implementation. This gives you an idea of the African region again, and this is domestic general government health expenditure as a percentage of general government expenditure. That is, all of government spending across sectors, health compared to that. And you see, this is not arranged in alphabetical order now, but you find Nigeria in front. Okay, you find us somewhere there. Next slide. Okay, so how much are we spending per capita and for health? Remember in my initial slide, I had said that there was a study done to calculate that what was required was about $86, at least to be able to achieve that benchmark of UHC. This shows you across 2010 to 2019 how much we have been spending. We are way below that benchmark. And it is important for people to know this so that as we, spend more, we're spending it in a strategic pattern, and that we are calculating and holding people accountable for the resources that goes into it. Next slide. We also try to group states in Nigeria across the 6 geopolitical zones, just to also give us a semblance of what states are doing relative to what is happening nationally. This is for the North Central Zone, and you would find the different states there, and you would also see how they compare with one another. Keep in mind that none of these spending is up to $85, which is in today's terms somewhere around 50,000 naira. Okay, so you can, any state you're interested in, you can just have a look and see how this is from 2017 calculations we did. So next slide. I'm still showing this because it's not significantly different from what's happening today. You would again see the different states. This is for Northeast. Next slide. So on the legend on the right, you would find those names that you can't quite see. The first is Jigawa, Kaduna, Kano, Katsina, Kebbi, Sokoto, Zamfara. The last one is Nigeria. Again, you find how expenditure is happening, and so the reason why I thought to show this is that documents like this and outputs of the National Health Account studies like this are very useful advocacy tools. If you put up stuff like this in the right audiences, people who are there would ask questions and could trigger some reaction that could further impact on health. Next slide. This is for the Southeast. And again, you would find how states are performing in the Southeast. And the next slide. This is for the South-South. Now, so this data represents a point in time, right, for 2017. It's not showing you a trend of these states over years. So when you're interpreting it, know how to, it's for the following year. Other states may have performed better than the states as they currently are, as you currently see them. Next slide. And this is for the Southwest. Okay, so the idea is to show you what your efforts, partners who support work across states, what it comes to. We would go in subsequent slides to look at programs, disease areas, and just see what this money is really meant for. Next slide, please. Right, so these line graphs show you who is really spending money in health. The very first line you have up above represents out-of-pocket expenditure as a proportion of current health expenditure. It has always been up there in the 70s, in percentages of 70s, upwards and above, over the years. The blue line shows you government expenditure on health. The red line shows you donor funds from outside of the country. And the yellow line underscores the point I made earlier on, insurance. Both the social health insurance, private health insurance, and everything we were shouting about insurance. That's the yellow line. So you can see at this point, health insurance is not yet mandatory. If it becomes mandatory, then perhaps the line is going to move above the other two lines, and we hope it's going to bring down that line up there. Next slide. Next slide, please. Next slide. Okay, so what's all of these funds that goes into health? What exactly are they used for? Now, the pie chart to my left would show you that a significant proportion of funds expended in Nigeria are for communicable diseases, 61.4% from the 2019 health account studies, 61.4%. However, we have non-communicable diseases now increasing, as we all know, because of disease demographics and epidemiology, 12.1%, reproductive health, 10.5%, and of course, injuries and some other non-specific causes. Of the proportion of communicable diseases, if you look at the pie chart on your right, you would find that the expenditure on malaria takes up about 36.2%, of course followed by TB and HIV/AIDS, in keeping with the global priority around the big three diseases because of all the attention that they get. However, we also have spending on vaccine-preventable diseases, a 4.7%, diarrhea diseases, and the rest. Next slide. Next slide, please. Now, significantly over the years as we conduct health account studies, we keep seeing that expenditure consistently on the current health expenditure consistently dwarfs capital health expenditure. We are trying to keep projecting this out there so that policymakers and those who spend resources on health can maybe change the dynamic a little bit. Next slide. Next slide. And this also shows you the different categories of expenditure: medical goods, curative care, preventive services, governance and admin costs, rehabilitation and long-term care. This reflects the different proportions of expenditure. Next slide. Now, primary health care, because of the Basic Health Provision Fund, the two lines you see show you the expenditure, one on primary health care services, and the red line shows you the proportion of those spending on primary healthcare services that occur at the primary healthcare level. So whereas people are getting primary healthcare services, most of the expenditure is happening at the secondary and tertiary levels, therefore removing all of the investments that could have happened at the primary healthcare level. Next slide. Okay, so with that last slide, what I had tried to do is to rejig our memories and brains a little bit on what healthcare financing is and what we hope that the result of all of the work that we do across states, nationally, and across the partner groups is in terms of universal health coverage. I've also been able to remind us of the National Health Act and the healthcare financing policy and strategy and all of the strategies and activities it outlines. And I've shared with you the data from the National Health Account studies that are conducted every year. They are publicly available in the Federal Ministry of Health's websites across the years from 2010 till date. And these are exercises that are ongoing, and to appeal to all of us when we receive calls for this exercise for data so that we can calculate this correctly, we should please do endeavor to respond to us. And to say that the exercise, this workshop and the accountability framework that is being developed is at the heart of what we had just presented in ensuring that the funds meant for healthcare do indeed get to those for whom it is meant. Thank you very much.
Great, thank you very much for that very, very powerful presentation. Shedding light on the health financing landscape in terms of policy landscape and at the same time in terms of performance landscape. I think you can summarize the performance landscape by saying in terms of how much we are spending, we are not doing very well, we are not there yet. In terms of who is spending, we are not there yet. And in terms of even the little amount of money that we are spending, what is the money buying? Put side by side, what can the money possibly buy? I think there are a lot of issues in there. I'm very sure some of us have questions, clarification, and contribution. I suggest we note our questions and contribution. The same applies to our virtual audience. They should try as much as possible to put their question and contribution in the chat box. We are going to visit those questions, and I'm very sure the doc is still available to answer those questions. Before we go for tea break, we'll take one more presentation, and then after which we will allow those that came in after the first set of introduction to introduce themselves. So we are going to take a presentation on the design and utilization of HSRC accountability framework. Please, let's upload the presentation. Or while they are doing that, should we take introduction of those people that? Okay, that's not the presentation. Huh? Okay, with introduction. Okay, so that's the consensus. Okay, great. Because this is democracy. Any new come here? Okay. Okay. Doc, you want to introduce yourself?
Morning, Dr. Gafar. Good morning, everybody. Chairman Hefon, other dignitaries here present, fellow attendees. My name is Dr. Henry Owunono. I am here on my own. I could have been here on behalf of Nigerian Medical Association. I've not been given the final pass to say that, but for now, I'm here on my own. It's refreshing seeing some faces again. Thank God COVID did not win. So let us use that energy, renewed energy, the warmth, especially at this auspicious time, to wake up everybody to talk about health. They have 100 million naira to pay for form like this. The health center in my village, there is none of us the ladies can never enter there to deliver. I will never allow my daughter or my wife to deliver there. But they have money to pay for 100 million, 40 million, and so on. because we have allowed them to be. I will stop here now, sir. Thank you.
Thank you very much. Okay, just come in so quick one.
Good morning, everyone. My name is Bello Halima Titulakwe, the Information and Youth Engagement Officer of Africa Health Budget Network. It's nice to be here.
Hello, you want to introduce yourself?
I've introduced myself.
Oh, sorry. Any new person here? Okay. Any newcomer? Okay.
My name is Rachel Chidmobi from Center for Environmental Sustainability and Development Awareness. Thank you.
Thank you. Any new?
Good morning, all. I'm George Monye from Majesty Community Rural Development Foundation, Majesty Foundation, and the Executive Director and also member FM.
That sounded like Manchester.
Good morning, ladies and gentlemen. My name is Edwin Jekeli from the House Committee on Healthcare Services, National Assembly.
Good morning, everyone. My name is Sati Marcel from the Budget Office of the Federation.
Good morning, everyone. My name is Yahya Mohammed from Health Strategy and Delivery Foundation.
Good morning, everybody. My name is Ifoma Chukwumerije from Health Systems Consult Limited.
Good morning. I'm Dr. Zara from Health Systems Consult Limited also.
Good morning, everyone. My name is Frances Ilika, Country Director, USAID Funded Health Policy Plus Project. Happy to be here.
BGD is my name, Health Reform Foundation of Nigeria.
Morning, everyone. I'm Rosemary Ayu, Clinton Health Access Initiative.
Okay, thank you very much. And so our virtual participant, please don't forget to put your name, designation, and your organization in the chat box as well.
Good morning, all. I'm Aminu Salisu Adamu, National Primary Healthcare Development Agency.
Good morning, all. My name is Hassan Ibrahim from National Primary Healthcare Development Agency, BHCPF.
Good morning, everyone. My name is Anu Rotimi from Center for Accountability and Inclusive Development, CAD.
Okay, thank you. Thanks for introducing yourself. So we'll be taking a presentation on the design and deployment and implementation of a HSRC accountability framework. Can we go to the next slide? Can we show it on the monitor here as well? Okay, thank you. So next slide. I'm very sure all of us are familiar with the concept of accountability, but the interesting thing is that accountability means different things to different people. So it's very, very important for us to set the stage in terms of what are we talking about, and then look at the framework that the HSRC has developed for health financing accountability, and look at how we have used it as so far. Next slide. So in terms of setting the stage, somebody says if you want to understand a concept, understand the caption first. So when we say accountabilities, so there are two root words there, account and able. So which is simply talking about how do we hold ourselves responsible for our actions and inaction. As simple as that. Of course, there could be complicated definition and everything, but basically here, we are talking about how do we hold ourselves responsible for our actions and inactions. But again, further setting the stage, if you look at the history of the world itself, even those developed worlds today, they migrated from a realm of impunity to the realm of accountability. And when countries are developing, when mankind are developing generally, two things are actually changing their lives as a society. Then they tend to move from impunity, that, Sati, I'll kill you, nothing will happen, to if I do anything, the system will hold me accountable. And the second thing that is changing in their life, they are becoming more equitable. They are thinking about everybody in terms of everybody having access to good things about life. Again, in terms of accountability, society becomes more accountable when there is freedom of speech, when people can speak and they can ask questions and they will get answer. But you know the interesting thing? As a child, children tend to be more accountable than adults because they tend to ask questions and they demand an answer. Recently, I visited a family, and the son was asking the mom, "Mom, why are you changing your driver every year? In 2020 you employed Andrew. In 2021, you employed Lukman. In 2022, you employed David." The mom said, "Shut up." And that is what we see commonly. You understand? We tend to, as much as possible, make people not to be accountable, to minimize their voice. And I told the young lady, you don't tell this child to shut up. Try to give this young guy the explanation. Try to explain to the young guy that, do you know what? We have other domestic staff in the house. We did not sack them every year because they are doing very well. These people that we actually sack, whatever, they are not doing well. So when people are doing well, keep them. When they are not doing well, kick them out. And the mom really appreciates it. But if you look at how all of us grew up, maybe because we are not accountable today because our parents actually suppressed our ability to ask questions. I'm just still setting the stage. And again, if you want to be effective, you want to be efficient, you want to be equitable, we must ask right questions. We must demand answers from everybody. And somebody says, do you know what? Most of the traditional rulers in Africa, there is a name that is common to them, at least where I come from. So it will resonate with some of us from southwestern Nigeria. They refer to traditional ruler as somebody that can never be asked a question. Kabikosi, ask him no. And it's not just about traditional ruler. It's an elitist something. If I'm powerful, nobody dare ask me a question. And that is the origin of impunity. That if I do it, nothing will happen. And we're just setting the stage in terms of where we are coming from and where we are having this type of problem we are having. And it's not only about health financing, it has implications for development generally. Next slide. So when we say accountability, let me go through some typology in terms of what types are we talking about. I don't dwell too much on that. But depending on who the actors are, depending on the focus of accountability, and depending on the subject of accountability. So we have political accountability where we hold our political class accountable, that if you are not doing well, probably we won't re-elect you. How well we are doing that, I'm not very sure, in terms of whether the voice determines whether somebody will be re-elected or not. Ideally should be. Financial accountability where financial control is the focus. Social accountability where the community themselves are holding the system accountable, are holding health providers accountable, that you are not providing the services and all those stuff. Bureaucratic accountability where later on, okay.
I'm sorry, but can I ask? Apologies, guys. Good morning, Dr. MTDC. Even with my glasses, I can't see. Yeah. So please, can you ask the question? I don't think I need it. No, what's the point?
So let's hold their hotel accountable. Huh? So let's hold them accountable because we actually paid for this to get a clearer resolution. In the interim, maybe we can switch off the light. Okay, okay. Absolutely, absolutely. So So let's raise the accountability bar. Okay. So the hotel, let's do the needful so that people will see. We have that to be closer. Great. But in the interim, can we switch off the light? Probably it will help. It will not. Okay, the camera people don't like that. Okay. That's great. So somebody is attending to that. Thank you very much, Dr. Ibekwe. Yeah, I'm very happy to have you here. So I was talking about in terms of typology. So we've talked about different types and legal accountability because we have legal framework. There are a lot of laws. Somebody said, you know, there's no respect for the rule of law in this part of the world. That's the truth of the matter. Because there's no legal accountability. Nobody is holding us accountable for what the law says, and as much as possible. But what is important about, we need the combination of bureaucratic accountability and next slide, please. I'll try to slow down so that we don't miss much where we're trying to rearrange get the technology right. Next slide. So again, what is the rationale? Why are we talking about accountability for health financing? In health financing, you can remind me, slogan in health financing is about two things. You can remind me, please. Not Francis, though. Not Francis and Francis. We have a slogan in health financing. Nobody wants to help me out. Basically, it's about more money for health and more health for the money. Everything that Doctor mentioned about health finance is just about two things. We want to spend more money and want to get more results for the money. Now, the level of accountability bar determines to what extent I will be able to raise more money. And it determines how we are going to spend the money well, whether we are going to spend the money well or not. So, I won't go too much into statistics. The doc has already told us we are not spending enough. Across all the benchmarks, somebody says, if you want to achieve universal coverage, if you look at those that are making progress in that direction, what they are spending, we are not spending that way. That means we have to do something. So I don't go through each of the indicators one after the other. The summary of it is that we are not doing well across all the indicators. Whether in terms of spending as a proportion of health spending, as a proportion of government spending, whether per capita spending, and the proportion of the GDP. That's why it's even the worst, because for country to make progress in the direction of universal coverage, it's recommended that they spend at least 5%. Government spend 5% of GDP. It's not only the money that everybody is spending. We are more interested in what the government is spending. It should be at least 5%. Nigeria is doing less than 1%. So that sets the stage in terms of spending enough. We are not spending enough. But how does accountability comes in when it comes to spending enough? In terms of government allocation for health sector, if you talk to them, Ministry of Finance, they tend to, 30 is here, is from the budget office. This is the man that has the knife and the cake in the budget office. And they will tell you that spending in the health sector is like a black box. You don't really exactly know what they are spending money on. So we want to spend more money in that respect. In terms of earmarking money for health, there is ongoing debate around the sugar tax, the additional 10 naira per liter that is added on beverage, on our drinks. Do you know that elsewhere, when they earmark such money, it goes to health directly. But the chief in the budget office says, no, we are going to earmark the money in Nigeria, but it's not going to the health sector, it's going to the central pool. We now say, why, Oga? Because Oga has the knife. It's Sati's boss that I'm talking about. And he has his own reason. He said, when you give earmark money for the health sector, they evade financial scrutiny. And you are not able to ask them questions, how you are spending this money. So as a result of that, the sugar tax will collect it, your eyes will see it. At the same time, somebody says there is even different, in Nigeria, there is a difference between, they say earmarking is earmarking. But what is more important is handmarking. So you earmark, but you don't handmark. So that is why accountability is important if you want to spend more money on health. What is even more important is efficient utilization, next slide, of the amount of money we are spending. Why is this important? A number of countries spend exactly the same amount and they get different results. Some people spend lower amount of money and they get better results than us. Efficiency. So if you look at this chart, each dot you see there represents a country. On the vertical axis is under 5 mortality, and the horizontal axis is looking at amount of money countries spend per capita. In summary, you just see that the arrow is pointing to where Nigeria is. This arrow is pointing to where Nigeria is. Despite the fact that we spend around, let's say around more than $60 per capita, even countries that are spending far lower are having lower under 5 mortality rate. It shows in terms of how efficient we are with the spending. So, and you see how some of this happen. Next slide. So, again, more health for anyone. What are the sources of inefficiency in the health sector? All of us know, but just to quickly remind ourselves. Number one, in terms of even how we organize our health system, we are not very efficient. When Sati becomes a member of House of Rep, when chiefs becomes members of House of Assembly, and they want to show the community that they are working, they will put one primary health care. And you have proliferation of primary health care, that some of them, they will be housing goats. And again, do you know what that is even more important? We proliferate those facilities. One, it is not even where they are needed. Secondly, we are not producing or providing other inputs of health, like health workers. Even the few health workers you now have, you now spread them over, and none of the facility will be able to operate 24 hours. And the women here know that, the deliveries at times come at night. And in the remote village, because we did not organize our health system well, nobody to attend to our deliveries and orders. And again, not only that, even the commodities, there are a lot of issues. I've seen facilities where there are a lot of expiries of drugs for a number of reasons. But probably the worst one is in the area of human resource for health. If you look at a typical health facility, a typical state, they spend 80% of their health budget on human resource for health. And that's where the biggest inefficiency comes. And I'll give you some example. I don't know who can see. I took this snapshot or screenshot of this day newspaper of sometimes in 2018. Can somebody read this for me? Okay. Did you see that? Someone, okay, maybe I will give you whatever to read it.
Sokoto uncovers 6,000 ghost health workers.
So when you hear this, what comes to your mind? What question would you like to ask? Ma? Okay.
So my question is, what's the proportion of healthcare workers? So that I know
Total population, right? Yes.
you know whether it's 1% and at what level?
Yeah, you see, you are too intelligent, man. So, that's exactly the question. 6,000 out of how many? 6,000 out of 13,000. Very, very serious. Okay, we are coming there. We are coming there. Do you know the person that made this pronouncement? Do you want to know who made this pronouncement? The executive governor of the state himself. But people should be more interested in what happened after. That's where we are coming to accountability. Again, look at, this is another state. I won't mention name of the states here. Please, I won't. Sorry, okay, I should be transparent, right? Oh, okay. So look at how health personnel budget increased from just 1 billion to 7 billion within the period of 2004 and 2012. And when we actually mined this data, when we analyzed it, a lot of things were actually, we're thinking of a lot of things. Is it that they recruited a lot of health workers during the period, or they adopted a new salary scale? But do you know what? They didn't adopt any new salary scale. What the salary change was marginal. But the most disturbing aspect was that there was an embargo on recruitment during this period. Okay, that's the question I asked when we saw it. And it's not in only that state. A lot of things are happening in many states like that. So we are so worried that how come multiple-fold increase in the personnel expenditure, yet there was an embargo on recruitment. You are not recruiting. And during that period, the density of workforce in terms of number of midwives actually reduced. To the extent that in some hospitals, they were closing down some wards because they didn't have personnel to work. So we are so curious. What is going on? Then we started asking questions. We went to the permanent secretary, everybody, and all of us, they were claiming ignorant that they were saying this for the first time. And somebody just called us. You have to be very careful. Many people are involved in these things. You are still young. Then we said, okay, we know what we are going to do. We are going to escalate it to the executive governor of the state. And the fellow we thought laughed at us. I said, why did you laugh? He said, the incumbent executive governor was the commissioner of finance when this thing was happening. And this is just to tell you how complex the work of accountability could be at times. Okay, next slide. So we'll quickly go look at some existing framework in terms of if we want to raise the accountability bar. What are the most important elements we look at? Next slide, please. So I won't spend too much time on this, but there are a number of them, but I will try as much as possible to emphasize on this one, which is looking at 3 important areas. One, you have to raise the transparency. People have to know. You can't hold people accountable for what you don't know. It's because we did the analysis of expenditure, spending on personnel. That was why we were able to ask questions. Before then, many people didn't even know whether the amount of money spent on personnel is increasing or not. So transparency is the number 1. Number 2, then you have to ask questions, and that try as much as possible to watch, to follow, to ensure there is a change. The good thing about the question that I use as an example, when the new executive governor came, we presented the paper again. They did staff auditing, and the governor took a lot of steps. They were able to recover a lot of resources, and they used, the savings to engage additional staff and were reviewed. So next slide, next slide. Let's move on. Now, let's move on. Yes, so I'm just going to the accountability framework that the HSRC now put in place. I show some of those framework to help us understand the basis for the framework. Next slide. So what is new? Because in development world, we use framework a lot. We use accountability framework a lot. So what is new in this accountability framework? Number 1, we are looking at all health financing mechanisms, whether government money, government discretionary spending, government earmarked money, donor money, because the donors are not absorbed of this issue of accountability as well. All of us, we are together in it. And then even health insurance financing mechanism. We look at everything holistically. Then it is action-oriented. Because if you look at most of what people say they are doing as accountability, it's only one aspect of accountability. They want to increase the transparency. They develop scorecard, for instance. The question is, and so what? What happened after the scorecard? Then two, we want to do combination of typologies. You know, I talk about political accountability, bureaucratic, financial, and everything. We want to bring everything together. And the multi-stakeholders engagement. So once the policymakers, the citizen, the legislature, the civil society, and the media. I don't know whether the media is represented here. Is anybody representing the media here? Okay. Thank you very much. You have a very important role to play. And it's not only at the national level and subnational level. And then the framework that we develop is meant to be adapted by different program areas. It's just a guide in terms of if you want for us, and that is why we are going to adapt this for the Basic Care Provision Fund. Then we are looking at it to be technology enabled. A situation, our vision is that our accountability framework will get to a stage where on your phone, you can click on something to know how much is spent by government of Kebbi on health, on family planning, versus what is released, what is spent, and what this money is. We are not there yet, but in terms of what is new, this is how it is envisioned. Next, we'll be looking at the theory of change in terms of what gives us the impression that if we do this, it will lead to this and get us the, before then, this is the process we went through. We did the desk review. We look at what is happening elsewhere. We look at our health financing landscape. We look at accountability framework of others that have been put in place. Then we design something. And then we went through a series of stakeholders engagement. My very good friend Anu is there. We did a lot of things together. She was always disturbing, where are we with this accountability framework and all those stuff like that. And then further review, and we hope that we'll validate and we'll continue to use. Next slide. Next slide, please. So in terms of our theory of change. So again, it's very, very simple. Number one is that to know, to act, and to change. We believe that if we know about a lot of things, about the rules, about the volume, about the process, about the input, about the output, about the impact, and we act based on this information, we are going to change something. It's as simple as that. Next slide. So in terms of transparency, to know, what exactly do we know, should we know, if we want to raise the accountability bar? Number one, whether Basic Care Provision Fund, whether spending on family planning. There is a cancer health fund now. I hope we know about it. They started disbursing money. Somebody said, sent a text message to me that each patient will be entitled to like 5 million naira or something like that in cancer health fund. Cancers could be very expensive. So, do we know the rules guiding whatever funding that we have? Basic Care Provision Fund, if we want to hold MOC, want to hold NHIS accountable, do we have a good understanding of even the operational guidelines and how it should run in the first instance? Do we have information about the input, what amount has been disbursed, who has received what, where is the money going, and what is the money by? What are the processes involved? The output, which facility has received the money, for instance? And again, outcome, how many people are actually coming to the facility? I will show you some interesting data in terms of from facility. We have started seeing improved outcome in some of the facilities. Who needs to know? Citizens need to know, the policymakers, the lawmakers, the media, and the social, and every other CSOs, and every other thing that you think you know. How do we know? Somebody needs to collect the information. Somebody needs to process it. Somebody needs to design in such a way that is very, very simple for us to relate with, what they call data visualization. A lot of people use scorecards, or they use infographics and other things, such a way to, and disseminate who is getting it. So, to know. Next slide. Perhaps this is the most difficult aspect of it, to act. Who is acting on those information? And when I'm talking about this, I remember a good erudite scholar. Let me ask, how many of us have read 7 Habits of Highly Effective People? The other time I asked the question, somebody says, I've seen it before. Yeah, I know you have read it. Who else has read the book? Please, if you're now going to read any book in the next 5 years, you must read that book. For people to be effective, it's like the Bible or the Quran and whatever of it. It's written by Stephen Covey. And he said, to know and not to do is really not to know. If we know something and we don't act based on that knowledge, you are not different from somebody that does not know. If we know that somebody is sleeping and we did not tap him, if you know that somebody is sleeping and you did not tap him, okay, I will tap. Okay, so I'm talking about to act, which is very, very important. Let me give you an example. When Okonjo-Iweala became the Minister of Finance, she was so disturbed that there are a lot of wastages at the local government level. And she said, do you know what I'm going to do? I'm going to publish all the allocation going to the local government every month. And when you open the pages of the paper on a monthly basis, you will see Gabi local government, so a month. So this is local, so a month. And they did it for several years, and nobody did anything with it. And they stopped. So it's not enough for us to know. We must use that information for decision making. And in terms of using that information, quite a number of things are important. You have to engage first. Because at times, the information you are able to gather, the people that will make necessary changes, perhaps they are not aware of that information. And let me give you an example. When I engaged Governor, my team, Frances is there. In 2018, I think Juliana was there as well. When we engaged Governor Wike of Rivers State, because we are implementing a project, and we did the analysis of our HIV/AIDS and financing and all the stuff, and the problems the HIV/AIDS team they were having. And when we presented to Governor Wike, and before I did that, I made sure I said a lot of good things about what he was doing in the state, so that I was able to get the audience. And when I was saying about good things, he now started very well. I was not looking at me. And when I now finished, he said, thank you very much, Doc. He now turned to his commissioner for health. He said, Honorable Commissioner, how come I'm getting all this information from an outsider? So the HIV situation is so bad in my state, and I'm not aware of it. Mr. Commissioner, you are the one spreading HIV in Rivers State. And you agree with me that the governor Wike can say that kind of thing. He actually said it. And the worst case scenario, as bad as the HIV situation was, the SACA, the state agency, did not even have an office space. He now turned to the SSG. He said, SSG, how come there's a huge problem like this? And the organization saddled with responsibility does not even have office space. You don't say, Your Excellency, sir, I just wrote a memo last month. I wanted to present to you and everything. Say, I give you 2 days, go and find them an office space. Engagement is very important because it's not in all cases that the people that were engaging actually, because we have the impression they know, they do not just want to do something. After engagement, when I'm talking about what we need to do, is we ask questions. We hold people accountable by asking questions. Why is this? What should we do about it? And again, I advocate as much as possible. Then in terms of who should know, the citizen, the policy, lawmaker, and media, all of us have roles to play. We have to sensitize people so that they know when they are equipped with information. I'm saying this because on basic healthcare provision fund, a lot of us will be pushing out scorecards. Scorecard on this, scorecard on that. And the question is that who is doing what with those scorecards? And how do we do it? There are a lot of fora for engagement. Of course, we have to know that engaging the policymakers at times could be very, very difficult. We have to use the right medium, the right people to get to them and do that. So, town hall meeting, policy dialogue. But more importantly now, we are in the electioneering period where the political class are asking for our votes. Do we ask them? One of the candidates 2 days ago, he said, I will make health free for everybody. Is the enemy asking questions? Is everybody asking questions that how are you going to make health free for everybody? What is your key policy trust? Where would the money come from? How do you build on the existing policy stuff? And the last aspect of the or the theory of change is to change something. Next slide. And again, we have to identify specifically what change do we want to see. It could be in terms of health indices of optimal funding, changes in efficiency, and conformity with the established rule. Again, who needs to change things? Policymakers, the providers, and depending on what the change we want to see. And how do we get there? Can we apply rewards and sanctions? And peer comparison. One thing that I know our governors are sensitive to, they are sensitive to peer comparison. So we develop a scorecard on the release of equity fund, and we get to the Nigerian Governors Forum Secretariat and present it to the governors. And when one of the executive of health insurance was telling me that his governor came back and said, the governor sent for him. I said, how come I'm having red here, despite the support I'm giving to you? I said, Your Excellency, sir, you are giving the support, but you are here to release the equity fund. How much is the money? Okay, go and get the half of it. So we have to know what works and what doesn't. So next slide. We are getting there gradually. So based on this theory of change, we now develop the matrix. So the matrix look at different aspects in terms of what indicators are we looking at across government discretionary financing, earmark funding, health insurance money, and others. So let's move on. Okay, so in terms of government discretionary money is the one that amount of money you allocate can vary. You can put, make a health budget to be 6% this year, 7%, 8%, and you can allocate it to which area of preference. So, apologies, this is not showing very well. So we have a number of indicators which we are looking at in terms of health budget as a percentage of government. Most of those indicators that the doc presented earlier on are here. And then we'll look at what is the target, what is the actual. But more importantly is the action. What should the lawmaker do? What do the executive do and CSO do? Later on, we'll give some, when some of the partners are making presentation, they will give some specific examples of how they've used this. Next slide. So in terms of earmarked money, don't forget, because all of us, we are so concerned about basic care provision fund. We have forgotten that there are other earmarked funds in the health sector. At the state level, states are supposed to be spending 1% of their equity, of their state equity fund, just like the federal level. As the equity fund, how many of the states are doing it? The last time I checked, they are not more than 6 or thereabouts. So, as part of the health financing accountability framework, you want to know whether they have allocated this money, what proportion have they released, and what are they using it for. Again, the basic care provision fund, in terms of, the law says not less than 1% of the consolidated revenue. And I'm very happy that our lawmakers are trying to actually increase that up to 2%. But how much is released, how much is spent? There are periods where there are a lot of issues with releases of these funds. So what do we need to do and what do we need to do about it? Next slide. Again, so in terms of the health insurance level, in terms of health insurance, so all of us are aware that at the state level, there is still social health insurance scheme, where states are expected to have their health insurance scheme, release equity fund, enroll people. But if you look at the state health insurance scheme, probably not the fault of those people managing things. They have heavily focused on the basic care provision fund, money coming from the federal government, and then the formal sector. And they were not actually making much progress in terms of the informal sector. People that actually need health insurance more are the ones not getting it. You know, I was speaking with a colleague that came to Abuja, one of the years of the store. He was very happy that he's making progress. He has enrolled 36,000 on basic care provision fund, 18,000 formal sector. And when I asked about what are the informal sector, the poor and the vulnerable and others, he said, okay, we are around 25 or thereabouts. And those are the people that actually need this health insurance more. Next slide. Again, in terms of national health insurance scheme, you know, The NHIS, I believe there's some people from NHIS. About 2 weeks ago, NHI had a parley with the partners to look at the updates in the implementation of NHIS. And in fairness to Professor Sambo, he has done a good job in terms of institutional repositioning. It was not what NHIS was before that it is today. And in terms of putting the ICT, check and balances and everything. But the question I asked, and what I told Prof, what is going to be the new frontier? When you call us next year to tell us about updates, we are more interested in how we have increased the enrollment rates in terms of what proportion of Nigerians are actually having health insurance, how many of them are poor and vulnerable, what the proportion of women, because we don't want to leave our women behind as well, and children, and the vulnerable population. So we have a set of indicators that look at different dimensions, and then in terms of efficiency as well. Next slide. Again, external funding. Our accountability framework should expand to external funding as well, because our external funding is not immune to inefficiency. And in other countries, there is a strong coordination of external financing. They actually use the principle of aid effectiveness as much as possible. Again, do we have a very strong coordination, donor coordination structure? We used to have at the national level, I doubt if it still exists, that bring donors together and align the financing to the priority of the country. Not donors saying, I want to do this. States, come and align with that stuff. No, shouldn't be. We should know our priorities and try as much as possible to align. It's actually happening in other countries. Again, availability of data. And this is very important for donor financing. And when we are trying to raise accountability bar, this is what we should try as much as possible to do. Our donors and partners, they position themselves as the watchdog. Is that not? But at the same time, it is easier to get government financial data than to get the donor financial data. So who is holding who accountable? Are we together? Are we together? It's a lot easier to get federal, state government spending than to get to the financial books of donor and partners. We shouldn't be. We should raise the accountability bar as much as possible. Somebody say, I'm shaking the table, right? Okay. And then other parameters are as well. And again, as much as possible, our donor funding, partner funding should not be replacing government money. It should not be fungible. There are a lot of areas where donors spend a lot of money. It's becoming very difficult to ask government to spend money in that area. Because government think, that's the domain of the donor now. Let my government use the money for road. Let's use money from BMGF to buy family planning commodities and all those. We shouldn't be. Next slide. Again, so it's not only about how much we have spent in terms of results. This multi-sectorial accountability arrangement should be looking at the results, the progress that we are making in terms of what the proportion of facilities having necessary commodity, and then in terms of impact, maternal mortality under 5 mortality ratio. Whenever they release NDHS, I will expect people to come together, NDHS, the National Demographic and Health Survey, and come together and say, how has Nigeria performed? How has Nigeria performed, given put side by side investment, the money that we have invested on it? So this is part of what we need to do in terms of the result as well. So let me quickly, next slide. So in terms of even the basic care provision fund that we started implementing. So this is from a project that we implement in Nasarawa State to look at facility utilization. Because ordinarily, in this part of the world, because of financial barrier, many people are not actually using health facilities. Am I correct? A measure of facility, are we together? A measure of facility utilization is what they call consultation per person per year, which means if we have 100 people in the community, how many times do they actually attend facility that one person we attend one facility per year. You'll be surprised that in Nigeria, on average, consultation per person per year is less than 1. Meaning if you have 100 people in a community, in the whole year, number of facility utilization will not be up to 100. Very, very low. And what is the benchmark if we must achieve universal health coverage? The benchmark on average says at least 4 consultations per person per year. I should be able to go to health facility at least once a quarter to check, to do some tests, to do this and all this stuff. But because of financial barrier, I'm not able to go. So what is now happening as a result of implementation of some of these basic care provision fund and equity fund? Now, so in that particular, each of these represent a facility. Now, so in this facility, there is a partner that actually brought money to buy health insurance for some people. They bought health insurance package for people, and they introduced community engagement process and accountability mechanism. And this particular facility, for example, facility utilization was as high as 4.8 or 5 consultations per person per year. Don't forget, among those people that have no health insurance at all, it was as low as 0.7 in that particular facility. And again, for those people that are on basic care provision fund, is good here, 3.5 is up. For the equity fund, is 2.5. But across those facilities, none of those facilities where basic care provision fund utilization was up to the one that was implemented by that project. Of course, there is improvement because of implementation, but it is not where we are supposed to go. So, if we increase accountability, and again, I was told that it's not like that in some states. Even with basic care provision fund, I was told utilization is not different from those that are not on any enrollment at all. I don't have evidence for that, but I was told. Okay, so next slide. I'm getting there gradually. So we have seen some results as a result of implementation of accountability framework. Later on, our colleague from DGI project, LISDEL, will tell us that at the national level, because of effort of some partners, they did an analysis and they discovered that in terms of health security, NAS represents National Action Plan on Health Security. Initially, it's a multi-sectorial thing. There's a lot of organizations, even Ministry of Agric is part of National Action Plan. But before, those ones were not getting allocation. So there was an analysis, there was engagement, they were now getting the allocation. In Kano State, because of analysis, engagement, there's a creation of budget line for health security, and they are getting the funds. The same thing applies to Lagos State. So this is just an example. Later on, we'll get the details of some of these results. So next slide. So in conclusion, and some of us are happy that I'm concluding because. So in conclusion, I think raising the accountability bar is in qua non of achieving development. We cannot make progress if we are not raising the accountability bar. That is very, very important. And mobilizing more money for health and achieving more health for money become more feasible if we raise the accountability bar. And existing accountability bar is only focusing on telling us about this is happening, that's not happening. We are not actually focusing on to act and to change something as well. The HSRC accountability framework is a template that is being adapted. This template for adaptation into different program areas, family planning, basic care provision for malaria and others. And again, there is need to adapt it to more program areas. But finally, effective deployment of accountability framework requires institutional capacity. We have to continue to train our capacity. It requires strong leadership. If we must come to equity, we have to come with equal hand. It's not, with clean hand. It's not enough to say I'm implementing accountability framework. We have to demonstrate, we ourselves have to be accountable in what we do. So that people will take us seriously that, okay, you are seriously talking about this. And again, it's unfortunate we don't have the National Orientation Agency here. We need serious value reorientation. I was telling somebody that at National Orientation Agency, what exactly do they do? Because there are a lot of things that require our reorientation. Orientation around equity, orientation around accountability as well, as much as possible. So because I don't talk too much, I would like to stop here and thank you very much for listening to the presentation. So again, because this is democracy, we'll ask our chair and everything. Should we quickly take our tea because it's getting cold? When we come back, we'll now take questions and move on. It's a democracy, but it will start from the others. Okay, doctor said he will forget. But I think there's a minority opinion, right? Should we go for tea break now, come back and have discussion? Okay, are we sure? It's only one person that is answering. Should we go for tea break now? Or we take the question and answer? Okay, Secretariat, how many minutes do you have to start with? Is the tea ready? This is 12 no, it should be. Is it ready? Okay. Okay. Yeah, how many minutes do you have for tea break? 10, 15 minutes because our time. Should we do like walking tea break? Our time is fast spent. Okay, please let's grab our tea and the next 10 minutes we'll continue. Thank you very much. Thank you, sir. Okay. So our virtual participant, please try as much as possible. I wish you can invite you to come and take tea with us, but please try as much as possible to put your questions and contribution. And okay, please help me to address some of those questions, please, so that yeah.